Assalamu alaikum. Good morning, everyone. It's my great pleasure to introduce Dr. Samuel Masket today. I'm sure he's very well known to everyone here, but just as a short introduction, Dr. Masket is a clinical professor of ophthalmology at the Giffen School of Medicine, UCLA, and the founding partner of Advanced Vision Care in Los Angeles. He served on the board of trustee of the American Academy of Ophthalmology and is a past president of the American Society of Cataract and Refractive Surgery. Dr. Masket has published well excess of 100 peer-reviewed articles and 2 textbooks. He served the editor of board for several medical journals, and he has been an invited guest surgeon and given a numerous named lecture globally. While his awards are numerous, his pioneer work in femtosecond laser in 2004 helped in revolutionary new method of cataract surgery. Currently, Dr. Masket is chair of the American Academy of Ophthalmology Senior Ophthalmologist Committee, and his clinical and research interests related to complex cataract and lens-based surgery. In 2013, Dr. Masket embarked on a new adventure with the establishment of the Samuel and Barbara Masket Foundation. The mission of the foundation is to provide ongoing ophthalmic clinical research and to deliver state-of-the-art eye care for patients with inadequate resources and professional education. So please join me welcoming Dr. Samuel, and he will present today the unhappy refractive cataract surgery patient.
Thank you, and good morning, everybody. Sorry, a little bit late. There was a terrible accident on the freeway with a car flipped on the side, so we're just a little bit late. I hope that this subject is of interest to you. What do we mean by refractive cataract surgery? You know, as you can tell, I'm old enough. I've been around at the very beginning of artificial lens implants. And when we started with lens implants, every lens had the same power. They were all 19 diopters. And we used to experience in highly myopic patients what we used to call the 9 diopter surprise, where you'd put a 19 diopter in a very elongated eye, and somebody comes in post-operative with 9 diopters of a myopic outcome. But as our technology has improved and as our ability to determine the right lens power has improved, patients have equated cataract surgery with, they model it as they do with LASIK. And they anticipate that they're going to have instant and permanent spectacle-free vision. And this is what patients really anticipate when they come to see you. Now, I do not know, and I apologize for not knowing, whether that is the situation with the patients who you see for routine cataract surgery here at KCASH. Surely out in the private world, I know you're anticipating that. And so as we prepare ourselves in training, and as we think of ourselves in community or in institutional practice, we have to figure out a way to manage patient expectations and to try and deliver what they want in terms of spectacle independence. And that's really what refractive cataract surgery is all about, trying to achieve elimination of spectacles. And this is, and we'll talk a little further about it later, what patients anticipate. Now, most often, true spectacle independence for a lifetime is totally unattainable. But patients don't really know that. And unfortunately, there's a lot of marketing by the manufacturers to the profession as well as to the patient population. And so we need to be able to educate our patients as well as try and deliver what they expect. There are a lot of, slogans that we should under-promise and over-deliver, but I think the most important thing is to properly educate the patients. So why would somebody be unhappy? We're going to take a look at the reasons for that, and we'll consider how we can help them post-operatively. So to me, in terms of dealing with the refractive cataract patient, and that also includes lens-based refractive surgery, where people have clear lenses but have refractive errors, where they may not be a candidate for corneal refractive surgery, or today with multifocality, trifocals, toric IOLs, toric multifocal IOLs, we may have better ways of dealing with the ametropias that patients have. So there are a lot more people, particularly in the West, in the States, in Europe, but also in Asia. This is a really burgeoning market in China, as well as it has been a long time in Japan. I cannot speak for the Gulf. I do not know what the population demands here. So I apologize again if this is not, specific to your needs. So I think it's important to understand your patient from the first time you meet them. And I present this more for the people in training than for the established attendings here. We all know this. But you must understand what it is your patient wants, what their lifestyle is, and what they really think cataract surgery is. So when you meet that individual, you're really trying to deal with what could be bothering them after surgery. There's a wonderful book recently published called The Art of Cataract Refractive Surgery. There are 3 lead authors. I contributed a chapter on the subject, and it deals with this. And I think this is probably most important to understand, and that is that dissatisfaction, and what we will define as premium IOLs are those that are designed to eliminate spectral dependence. Toric lenses and diffractive optic lenses is often associated with misdiagnoses prior to surgery, emphasis on the ocular surface, and occult maculopathy. Patient expectations may exceed technology, and very often they do. A realistic view of the optical and physical conditions in combination with a careful discussion of surgical options prior to surgery benefits the patient as well as you. So you're a team. True spectral independence is the desirable goal, but may be difficult to achieve for some patients and impossible for others. Assuming no meaningful surgical complications occur, patient dissatisfaction is most often associated with induced or worsening ocular surface disease, ametropia, and pseudophakic dysphotopsia. Contemporary surgery is commonly associated with induction or worsening of pre-existing dry eye disease, resulting in foreign body sensation and fluctuation of vision. The latter may be quite problematic with respect to diffractive optic IOLs that tend to reduce contrast sensitivity. Despite ever-improving IOL power calculation formulae, roughly 80% of cases can be expected to fall within a half diopter of the intended optical result. Negative, positive, and diffractive optic dysphotopsia may occur individually or cumulatively after surgery. So that's basically the subject. Now, this has become a very big topic of conversation, and you can see what they show here on the cover of this recent periodical, The Unhappy Premium IOL Patient, and there's a lot of talk about this of late. Now, cataract surgery starts and finishes with the incision. The purpose of the incision is not only to give us hermetic sealing to reduce the risk of infection, but it's also to limit surgically induced astigmatism. Some surgeons use the incision on the steep axis to reduce pre-existing astigmatism. My preference always was to operate temporally because of all the ergonomic benefits, and also less SIA, or surgically induced astigmatism, and then where appropriate use toric IOLs. But with regard to, as I mentioned yesterday to some people, both incision stability and induced astigmatism if you have a small and square incision, that is the most stable situation you can get. One of the things that I see people do incorrectly, and let me pause this video if I can, is they tend to overfill the chamber with OVD when they're making their incision. A very firm eye will tend to give you a short tunnel, so the incision will not be anywhere near square. Whereas if the eye is too soft when you make that incision, the tunnel will tend to be longer, and sometimes too long. And then you get kind of what we call oar-locked when you try and make your manipulations with the phaco or other instruments. So be careful not to overfill the eye. And I don't know whether there's a preference for steel or diamond blades. I happen to prefer diamonds because I can dissect pocket back and forth before I enter. So I like to make the grooves so we have a square external aspect. And here at the end of surgery, you have to hydrate the roof as well as the sides of the incision. And I set pressure at physiologic levels, and I measure with a tonometer, and that tonometer has 21 and 15 millimeters. And then I always do a Seidel test on the incisions to be certain that there's no leak. If the incision is well constructed, doesn't leak at the close of surgery at physiologic pressure, it's not going to leak postoperatively unless they have a filter or some other reason for hypotony. But a well-constructed incision will not leak after surgery. Now, in order to do refractive cataract surgery, you need to optimize your own outcomes. You need to know exactly what it is you get. So if you calculate, I need a 19 diopter IOL to create emmetropia in this eye, all right? You have to make sure that your outcomes match what you predict. And so you should each do this individually. Have your patient a subjective refraction, and I think it should be somewhere 3 to 6 weeks after surgery. Too soon, you don't have the incision stabilized and healed. Too late, you start to get into capsule changes. The lens can shift inside the bag. That's a different subject. But in terms of what you achieve for what lens you think the appropriate lens to put in, one of the things you want to do is you want to do this roughly 3 to 6 weeks after surgery. And I believe that a manifest subjective refraction is the way to go. I don't trust autorefractions in pseudophakic patients. So then you have to optimize your own aconstant. Now there's a wonderful book that comes from, this editor is from Indonesia, on IOL power calculation. And I can get it for, I think it's available online at no expense, but I have, and at the end I'll give you my email address, and if you send to me your request, I'll email this to you. It's a PDF, and it's a very, very simple thing. It's a wonderful book. I think it's the best book on the subject today. Also available to you at no charge is the ESCRS IOL power calculation. It has a lot of the newer formulas you can see across the top, those that use AI as well as the more traditional second, third, and fourth generation formula. And they also have a toric model for it now. So this is free. The other IOL power calculation book is also free for your use. So, you know, the tools that are available to us today are just numerous. You know, I've been around, as I said before, when all IOLs were 19.5 diopters. But we have a lot of tools to help us with this today. I don't know, CRST is cataract and refractive surgery today. This is a free periodical, tabloid, call it what you will. I don't know if this is available here in Saudi Arabia, but the publisher, BMC or Bryn Mawr Corporation, really wants to reach trainees. young ophthalmologists. So if you write this down, look online for it, you can get it at no cost. And they have a whole series of articles recently dealing with how to optimize your own A constant. And you can see here also, there's a wonderful podcast on the subject from somebody in Australia. And by the way, all of these slides will be available to you so you can get this. So in terms of your postoperative outcome, we call it A constant optimization, to know what you get for what you predicted. You also want to be able to determine what your typical incision induces with regard to astigmatism. All right, and so Warren Hill is an example. This website right here will get you to, you plug in your pre-op astigmatism, your post-op astigmatism, and they will determine for you what is your SIA. So you'll know if somebody has preoperatively, let's say, 1 diopter of against the rule astigmatism, they will help you know whether or not you need to consider a toric IOL for that patient. And there have been a whole series of articles in the Orange Journal, a Journal of Cataract and Refractive Surgery, on how to analyze surgically induced astigmatism, the best way to do it, and to establish what is called the centroid, as you see in this. So take advantage of these tools that are completely free and available for you online. So I started by talking about the physician-patient relationship. And as I said, I think it's our job to educate people as to what we can accomplish, not only for everybody, but for them in particular. So we're a team. It's not a combat. You don't want to get into argument. You want to realize that you work together. The more time you spend with the patient prior to surgery, the less time you're going to have to spend after surgery explaining what the outcomes of surgery were. Now, I know here at KCASH patients don't pay, but in the private world they do for what we call premium IOLs. And that brings a whole new subject of what I refer to as consumerism, when people have to reach into their pocket and pay for the service you're providing. It's a very different relationship when you are now basically selling something. And what you're selling is the reduction of spectacle dependence. So if you don't achieve that, you're going to create a greater degree of unhappiness. And sometimes this requires that we actually have to pamper the patients. You need to know what the IOLs can and cannot do. Now, this slide here is with regard to the early generation of multifocal or diffractive optic IOLs. But some of this is still basically true, and that is, in the States we had 2 basic lenses. I know you have more options here. We had either the Alcon series, the Restore series, or the J&J, the Technis series. And among the differences between these lenses is whether you have a full diffractive optic as with the J&J, and so it's not pupil dependent, but a greater likelihood for nighttime difficulty. And the Alcon series that you see down below, where only the central portion, 3.6 to 3.8 varying with the lens, is the diffractive portion. Peripheral to that is just a refractive portion of the lens, so that at nighttime, or with a dilated pupil, or a patient who has an innately large pupil, they're going to have less light energy devoted to their near vision. So you need to be aware how the lenses work physiologically. What are the optics behind it, in order to determine, based on the patient's lifestyle, their pupil, etc., as to what might be a better IOL choice for them. They also, this is a very interesting recent contribution from Uday Devgan, and where he talked about, there's been a shift away from the standard bifocal as the original Restore with distance and near and this gap in between, to lenses that more match the way people live, working on their computers, working on their phones, looking at the dashboard. So that more intermediate vision is needed today than it used to be. So those lenses that enhance our intermediate vision or extended depth of focus, called EDOF lenses, are also potentially pupil dependent. I don't know, do you have the Vivity IOL here? Yes, so the Vivity IOL, this is a lens that has a little button in the center that's non-diffractive. But as you can see in this demonstration here, with a standard 4.5 millimeter pupil, the patient will get both near and distance effect, or EDOF effect. But if they have a small pupil, they're only going to get that intermediate vision, and that will make them myopic for distance. Whereas with the Symphony, which is a full diffractive optic, pupil size doesn't matter. So you need to understand again how these lenses work. So how do we determine, right, what's the best way to build our armamentarium in dealing with these lenses? 5 pearls. Choose your patients wisely. Be supportive. Do the best you can to get emetropia. When you need help, use it. And then, most importantly, if you're going to put these lenses in, you need to know how and when to take them out. Just like when we started with foldable IOLs, it may be a surprise to you, but there was a time when lenses were all rigid. We didn't have foldable IOLs. Yesterday I watched a surgery with a 7 millimeter PMMA optic in a patient's eye. That was the most, I mean, I've seen it all. So we didn't have foldable IOLs. At that time, we needed to know not just how a foldable IOL worked, but how we got it in. There were a lot of difficulties, lens damage, eye damage with the inserters. Now that technology is not a problem, all right? But what is a problem is how to get them out and when to get them out. We'll talk about that. I say avoid the opathies: keratopathy, optic neuropathy, pupillopathy, zonulopathy, maculopathy, and most importantly, what I call psychopathy, people who are not mentally appropriate for adapting to diffractive optic IOLs. Here's an example, if you don't evaluate the patient properly. Yesterday we had a conversation about topography versus tomography. I still adhere very strongly to the use of corneal topography based on placido imaging to give you a sense of the tear film and the ocular surface. Here's an example of a patient looking at this topo. You can see it's massively irregular astigmatism. And if you would just to look at this and say, oh, I can read almost 5 diopters of astigmatism, this patient had EBMD and a Salzmann's nodule. And so once we treated that ocular surface by removing the nodule, et cetera, patient had basically a very, very normal surface and a half diopter of insignificant astigmatism. So you really have to pay very careful attention to the ocular surface. Here's an example. This is a patient referred to me following, she had a toric lens implanted, and then postoperatively, the surgeon again refracted the patient and noted that it seemed like the toric lens was off axis. So he attempted to rotate the lens, and in so doing, tore the capsule and damaged some of the zonular fibers as well. So we have here now a malpositioned lens and an open posterior capsule, and an obviously unhappy patient who paid for a toric intraocular lens. But what this doctor had, what the surgeon had not done preoperatively, was pay attention to the ocular surface. So you can see here on this axial view, there's clearly irregular astigmatism, right? You can see this hot spot here, so to speak. And why I really like placido imaging, if you look on the lower right, you can see how irregular the Meyers are, even here in the center. So not using topography to evaluate this patient prior to doing a toric IOL was a huge mistake. And then rotating the lens, because now the astigmatism was different, was even a bigger mistake. because he didn't, he just, he then went out with surgical complications. So we treated the ocular surface, we debrided the epithelium, etc., allowed the eye to heal, and then 6 weeks later you can take a look. Patient has a basically very, very normal ocular surface. Again, is viewed here. You can see basically normal placido imagery. Again, a very insignificant amount of with the rule astigmatism. And we just exchanged this patient for a non-toric IOL. It had to be scleral fixated. Now, very commonly in my environment, and obviously common in your environment, with dryness and now horrific air pollution, you have the potential for very dry eyes and a very fragile ocular surface. When you subject a patient with a fragile ocular surface or dry eye to surgery, you make it worse. There's almost no chance you won't. The medications, preservatives, frequent drops, drying during surgery, et cetera, you're always going to worsen that ocular surface. Effect on the goblet cells. I mean, there are unending number of reasons why we worsen the ocular surface. So I know many people are now optimizing, what they say, optimizing the surface with lubricants, steroids if necessary, very careful attention to the lid margins and what have you, before they'll even do their preoperative biometry. They place everyone on topical medications, lubricants, etc., and then they'll see them back a few weeks later and do their biometry at that point. So during surgery, in someone who has a fragile or fragile surface, I never put tetracaine on the ocular surface. Tetracaine, unlike like proparacaine as an example, will tend to break down the desmosomes between the epithelial cells, and you're more likely to induce an abrasion. And if you want to create a very unhappy refractive cataract surgery patient, give them a central abrasion during cataract surgery. They wake up in pain and they can't see. You've not made a happy patient there. So you have to be very, very careful about the ocular surface. So I don't use tetracaine on the cornea. I will use tetracaine around on the limbus. I'll put it on with a Wexel. And I also use a surgical drain, and I'll put tetracaine on that in the cul-de-sac, but I don't put it on the cornea. I lubricate the surface frequently with HPMC or hydroxypropylmethylcellulose. The commercial brand OcuCoat we have, made by B&L. And when anyone has a fragile surface, I use non-preserved drops post-operatively. Because if those of you who see a lot of glaucoma patients on a lot of medications, their ocular surface is always a mess. Those medications are poisonous to the surface. So when dealing with a refractive cataract surgical patient, try and avoid preservative if you can. So here's such a situation. I'm marking the cornea for the capsular excess, and then HPMC goes on. Then under HPMC, we do the rhexis, and I repeat it frequently. It also enhances your view significantly. And by the way, if you have a patient, here I have to clean it up because I do intraoperative aberrometry. As you can see here, I'm measuring during surgery the astigmatism and the refractive prediction. But then as soon as I'm done with that, I'm going to put it back on the eye. And then here at the close of surgery, and someone has a very fragile surface, and I use fluorescent to check every incision, I will frequently use a BCL. And anyone who has preoperative dry eye, or if I see any change in the epithelium at surgery, take the BCL off the next day, and very often that surface looks terrific. By the way, if you have somebody who has epithelial disease, and you're doing a complex case, don't hesitate to take it off. It'll enhance your view. Put HPMC on, you'll see much, much better. I actually learned that from the retina people. I said be supportive. Let patients know the truth, that they don't always work. The literature is replete with articles on dissatisfaction with multifocal IOLs. Here's two examples from JCRS. We reported our own outcomes, which I'll get to in just a moment. But I love this study. Again, technology has improved, particularly with trifocal IOLs. The dissatisfaction is definitely less than it was before because we've eliminated that dead spot from the bifocal. But understand, this is a great study. This was at Moorfields. They randomized patients to receive, all good candidates, to receive either bilateral monofocals or bilateral multifocals. And they found that they had to explant almost 6% of the multifocal IOLs, 0% of the monofocals. So if a patient's having significant difficulty after surgery, I share this information with them. I also will share it when a patient is questioning preoperatively, should I or shouldn't I let them know that there is a significant incidence of dissatisfaction despite best case situations. I talk to them if they need to know. I let them know that in the original FDA trials of both here, the Restore, and here, the Technis, that only about 90 to 93, 94% of patients who didn't pay for them in the FDA trials, so they were free to them, but only about 90-some percent, low 90s, say they would have that lens again. So that's important to know as well. Now, Alcon has recently promoted that 99% of their trifocal IOL, the Panoptics, would have it again. I'm not so sure of that, but it is definitely newer technology, and some of the trifocals that you have available from Europe, which we don't have in the States, are better. But I also tell them about the difference in the visual disturbance. They need to know these things, the optical side effects, and they're quite similar between those two. This is the experience we had. We exchanged 64 eyes in a certain period of time, people who had diffractive optic IOLs. And all of these were either emmetropic, where we had fixed their refractive error, and they had no disease. There was no ocular surface disease and no maculopathy. And 42% of our exchange patients were emmetropic and no comorbidities. So again, we have our practice, we're a referral for unhappy patients. We specialize in that. But the long and short is that despite your best efforts, there are, I'm driving this home, there are a number of patients who will be unhappy. And there are reasons for this. I love this study that was in the AJO, and this came from Japan, where they looked at contrast sensitivity. I think there were 50 patients in the study. Contrast sensitivity measured with the diffractive optic IOL, and then after it was exchanged, and you can see here the lower traces contrast before exchange, and then how it improved significantly after exchange. So all of this is to have you recognize that diffractive optic IOLs have their downside. They have their upside. They really can achieve spectacle independence. But there's a trade-off in terms of nighttime difficulty with driving, halos, etc. Achieve emmetropia. I mean, this is the holy grail, so to speak. How, if I told you before that 80%, now Warren Hill and others are saying that, well, we can really get maybe 90% within a half diopter. Well, that's only 90%. There's still 10% of people who are going to be outside of that. And very, very few studies really show that you can get 90%. It's more like 80%. So this is also important to understand the effect of astigmatism on vision through diffractive optic IOLs. Take a look at just with a half diopter. Take a look at this with a 4.5 millimeter pupil. Look at the difference in image quality. So that's, this is very significant. This is also a study with looking through adaptive optics on the effect of astigmatism on the quality of vision in patients with monofocal IOLs, single optic accommodating IOLs, which don't always work, and then apodized, the Alcon type, and in blue, the tetanus type. You can see once you get above a half diopter of stigmatism, you really have negated the value of these lenses. Now, this is something I've been involved with the FDA, with the American Academy of Ophthalmology, with IOL manufacturers, and with people, UCLA and the RAND Corporation developed what's called patient-reported outcome measures, a PROM, a P-R-O-M. I started with this in 2014, and we just completed the development of the PROM and published this in the July issue of the Blue Journal. And the reason I share this with you is the FDA is now interested. The approval process for IOLs will also include how patients view the effect of these lenses. And that's why it took such a long time to develop this. It's a very, very important situation because COVID got in the way as well. So it's called the Assessment of Intraocular Lens Implant Symptoms. That's what this was called, and I've been involved with that. I said I chaired the most recent aspect of it. But what this was designed to do was to assess visual symptoms, general perceptions of vision, and the amount of spectacle or contact lens wear. It looked particularly at symptoms post-operatively, 14 ones in particular. And I don't really need to bore you with all the details. This was the thing that I took away from this, and that is that patients tended to be more concerned with spectacle dependence than they were with quality of vision. So that if they didn't need their glasses, their side effects were far lower than if they were ametropic. So I was surprised by this. You know, I wouldn't trade quality of vision, probably because of the nature of my work. But patients really want spectacle independence. And as I said along, symptoms worse with ametropia, and patients greatly value spectacle independence. So that's the essence of that. But how do we achieve ametropia? 5 A's. Stigmatism control, accurate biometry, appropriate formulae. Although it's difficult to prove in the literature, I believe intraoperative aberrometry is beneficial. Has it been used here at KKH at all or in the kingdom at all? No. And the ability to adjust the outcome. Now, this is something that is now available. Is the light adjustable lens available here? No. Okay. It will be. I'm certain of that. But adjusting the outcome in the future, you will be able to change the power and the cylinder of an intraocular lens that's already being planted. We have such a device, the light adjustable lens, in Europe, in the United States. I don't know where else at the moment. It's expensive. Patients pay a lot for it. But a few weeks post-operative, they can have the outcome adjusted. But as I said, it's expensive, and there have been problems with some patients because you have to protect that lens from ultraviolet light in the early post-operative period. What's coming down the road even further is actually the ability to use a femtosecond laser to sculpt the pre-existing acrylic IOL that's inside the eye. It does it by creating a Fresnel lens inside. So let's talk about the 5 A's. So wrong power IOL is still a major cause for exchange. If you have a post-operative surprise, the first thing you need to do is try and figure out why. I mean, that's really essential. You need to remeasure, do biometry right away, make sure that you take a look that your surgical plan is actually what the lens that was implanted, check ID numbers, etc. And then share the information with the patient. It's much better that you work as a team together, share it with that patient, than they hear it from the next person. We have no shortage, coming shortage of ophthalmologists. Right now we have no shortage of ophthalmologists in crowded cities. So, and that's how you create a very unhappy patient, is not tell them what's going on. So, how do we manage people who wind up with ametropia? Well, going from least expensive, least risky down spectacles, but they didn't want to wear glasses in the first place. They paid you money so they didn't have to. Contact lenses. Now, if a cataract patient, particularly someone in the cataract age group, has not been experienced with contact lenses prior to surgery, it's unlikely that they're going to adapt well to them postoperatively. But we use them a lot for trials. So if we see a patient referred to us who wound up with monovision and didn't want it, or wound up hyperopic and didn't want it, not so much with the latter. Somebody who has induced hyperopia is not going to tolerate it well at all because they can't see well at any distance without correction. But somebody with induced myopia who has near vision may actually miss it if you take it away. So before we fix it, we put a contact lens on that patient. And we say, we want them to know, look around the room, go outside, you're definitely going to see better far away with this lens, but you're going to lose your near vision. And sometimes they realize they don't want it. Or you can titrate the amount by varying power contact lenses. So we use them for trials. Going down the list then, now we're going to, if contact lenses and glasses aren't options, then laser refractive surgery, secondary IOL, add-on piggyback lenses, or probably the most physiologic is to change the IOL. The problem there, though, is that there's a mystery. In every one before that, you're correcting the error without knowing why it's there. If they have 2 diopters of myopia and you're going to do laser correction for 2 diopters of myopia, you're going to fix it. But if they have a wrong power IOL and you don't know exactly what power that lens is, let's say it was done elsewhere, what have you, then there's a little bit of a risk that you're going to put in a lens that also is incorrect. So even though it's the most physiologic, it's problematic. Now, with respect to laser refractive surgery, I really strongly prefer LASIK over PRK or surface ablation because it takes surface ablation longer to give the correction and it can be painful. So you have an unhappy person, you now subject them to surface ablation, they're not going to be thrilled. Whereas if you're going to do, and if they're candidates for LASIK, they're going to be much happy. You can, one day post-operatively, you're going to see better and going to be comfortable. The problem, though, with LASIK is that you have to wait a while for wound healing. You don't have to wait that. All you have to, for surface ablation, you only have to wait for refractive stability. But because of the suction necessary, we really don't like to do LASIK before at least 2 months after surgery. Then the other question comes in, the fee. So you now, my advice is never to charge an unhappy patient. But if you have a patient referred to you and you're going to do LASIK, I think that's fair game. Now, piggyback lens, I said, it deals with the known error irrespective of the cause. But the first lens has to be in the bag and it has to be stable. You can't have a lens moving around and put one on top of it. Question then is which power IOL and which IOL? I really prefer silicone IOLs in the sulcus to acrylic lenses, particularly ones of low power, and we'll get into why. But we've lost a lot of the lenses. Star, I don't know if you had Star lenses available here. They had a low power series available from -4 to +4 in 1 diopter steps, had 14 millimeter loops, so they centered well, but those lenses are no longer available. But Bausch & Lomb has a silicone lens. It only goes down to 0. It doesn't have a minus lens. For minus lenses, we have in the US the Alcon MA series and the J&J AR 40M series. This is among the reasons why I don't like low power acrylic IOLs. If you can see here, this inferior iris is really beaten up, moth-eaten. And if you look here, you can see there's a little bit of blood on the hyaloid face. This patient had at cataract surgery, a 2 diopter Alcon lens implanted. Now that's a meniscus lens, very low power, and in order to make a meniscus lens, it has to be very thin in the center and thick on the edges. The Alcon material tends to be tacky and abrasive in the sulcus. So what happened in surgery was, this is a right eye. The loop on the right side is in the sulcus. The surgeon missed the bag with the second loop. The first loop, which is on the right side, is in the bag. And you can see up top, the lens is in the bag, and you've got this overlying anterior capsule, so there's no damage to the superior iris. But because of the missed loop on the temporal side, the inferior optic is sitting in the sulcus and has beaten up this iris significantly. So that's among the other thing is very low power acrylic IOLs tend to have a lot of reflections or dysphotopsia. You can use the Holiday Virgins formula, but a rule of thumb, particularly these are low errors. It's easy to correct them. There's a little trickery in the optics, though. For a hyperopic error, spectacle error, you multiply by 1.5, and that is what you put in the eye. So, for example, a patient is +2 on refraction. You put in a +3 in the sulcus on top of the existing IOL, you'll achieve emmetropia. It's a little bit different with myopia. There you use 1.2, so it's a little bit lower corrective. And then, of course, you can use the Holiday Virgins formula. And there's also a thing called the Bilesman nomogram. And this was designed for those star lenses, unfortunately, that are no longer available. Now, here's an example. This is a patient who was post-LASIK and who had touch-up. And as you can see here, also there's a little bit of a decentered ablation. You can see this, unfortunately. And I don't know if that occurred because the patient came to me following cataract surgery after the LASIK, and she had myopia as well as astigmatism, but also there was another problem. So taking a look here, we can see, and remember I mentioned pupil size. So this patient, her mesopic pupil is almost 6 millimeters, right? And she has here well, we'll get to it here. She had about a diopter or so of uncorrected astigmatism. I mentioned before accommodative IOLs. Did you have the crystal lens here? Yes, right. The crystal lens was a lens that was designed that it had these haptics that are supposed to bend and allow the lens to move forward with accommodation. It never happened. Actually, the lens sometimes moved backwards, didn't move forward. Actually, some patients did get pseudo-accommodation, and it still was a mystery as to why. There were some very happy people with this IOL, but not a lot. The other thing is this lens had its own series of complications. But among the problems is the size of the optic. So here this is a 5 millimeter optic in a patient who has a 6 millimeter pupil. That's not going to work very well. And she had uncorrected astigmatism as well. So rather than, you really did not want to consider surface ablation. This is before we had topo-driven, and I don't think still after 2 procedures you would want to do that. So here I'm going to do peripheral corneal relaxing incisions for the induced astigmatism, and this was a -2 lens that went in to correct her ametropia. Now again, unfortunately, this 6.3 millimeter optic, and you see how nicely it covers that 5 millimeter optic, is unfortunately no longer available to us. Remove and replace. Again, the problem here is it doesn't address the known optical error. So you need to figure out why that lens is the wrong power. The sooner after surgery, the better, because the longer you wait, the more changes in the capsule. Here's an example. Again, why I don't, this is a patient, I think this is a 2 or 3 diopter Technis IOL. Patient's not that far, maybe 2 months after surgery. And I separate the anterior and posterior capsule with a laser spatula. A 3-piece IOL is very easy to remove. And because they're so thin, They're easy to hold on to with a serrated microforceps and using a 19-gauge scissor through a 2-2 incision. Important, when you take out a 3-piece lens, make sure the loop optic junction comes out first. And so you rotate it to bring it out first. If you have it trail, that loop can swing around, can damage the endothelium, damage the capsule, damage the iris. What I'm doing here is cleaning the LECs to prevent capsule contraction, phimosis, and also it enables you to exchange lenses more readily. And again, here that lens is going in, that this lens is no longer available. We don't need to see that. I said get all the help you can. What I mean by that is there's a lot of technology that can help us, particularly with toric IOLs. It's not rare that they will rotate. In fact, we've learned that they rotate usually within the first hour after surgery. That's really when it happens. But when is the best time to rotate them? We like the capsule to have a little bit of fibrosis and tackiness to it. So somewhere between 2 and 6 weeks is probably the best time. It's the most challenging surgery if the posterior capsule is open. Very often you can't rotate a toric lens. You have to correct it some other way or exchange it. The only other thing you can do is what's called reverse optic capture, where you bring the optic anterior and rotate the lens on axis. But you'll have to do vitrectomy as well. But here's an example of a case where I used available technology. So this patient had prior radial keratotomy with also astigmatic incisions. And she'd had cataract-based surgery. They placed a very high, the T9, and according to the surgeon, the patient, the lens rotated post-operatively, and you can see here it's sitting at about 150 degrees. But the refraction, you can see this is a very dissatisfied patient following surgery. Best corrected 20/30 minus and a T9 off axis. Now, I'm not a huge fan of toric IOLs in post-RK eyes. Do you have RK? Was that done? Yeah. I don't know what technology you have. Anyhow, as you can take a look here at the topo, particularly the rings, I don't know if I would have advised this patient. They really look like there may be 3 axes here. So I don't know if this was advisable, but they measured about 4 diopters of corneal astigmatism. So I understand why the surgeon did what was done. But what we have available to us, are you aware of this thing called astigmatismfix.com? No? Yes? Okay. This is really helpful. You plug in the numbers that you have, and it tells you where to put that lens so that you eliminate the astigmatism. So in this particular case, we only had to change it by 18 degrees to get it on axis. But you have to go clockwise. So it's really 160 some rotation. Also, intraoperative aberrometry is very helpful, but you also have Callisto, which is also very, very helpful in terms of your corneal axis. So here at surgery, I'm going to use this femto spatula to get under the anterior capsule, and I find that the best way to do it. And then we're going to place OVD, low molecular weight so it spreads easily. And then you really have to open the bag out to the equator. And here, sometimes, as you know, this is the Alcon type, and we'll get into that a little bit later. Getting these out of the bag can be difficult. So if you hold on to it with a micro forceps and then use blunt and viscodissection in front and behind, you can free up that adhesion around that end bolt of the Alcon lens. Sometimes it's a little bit easier on one side, but again, the trick is to hold it with a micro forceps and then manipulate it. If you want to exchange a lens, sometimes it's a lot better to cut the haptic. And then again, you open the bag for 360 degrees so you eliminate fibrotic channels. And then in this situation, again, you won't be able to see the aberrometry, but the light will go off. So now I've got the bag open. I'm going to place the lens in the expected axis. And then I'm going to do intraoperative aberrometry. So this is the axis on which we want to place the lens. I placed it there. I'm going to set pressure at physiologic levels with the tonometer, and then we're going to do our intraoperative aberrometry. Unfortunately, not all our machines have the available readings. And then here at the close of surgery, we're just going to set pressure at physiologic, as I mentioned, and then the surgery is completed. And this worked out rather well for this patient. She then became almost hemetropic and a much happier indeed patient. Need to know how and when to exchange, as I mentioned. And surgeons are particularly wary of IOL exchange in an open capsule. And this is a patient, we've seen many patients who were referred to us. Their doctor, the first thing surgeons do when a patient is unhappy with a multifocal, they open the capsule. And it makes me crazy. If a patient is unhappy from day one, they're never going to be happy. Maybe they're going to neuroadapt, but if they're very symptomatic, that's not going to improve. PCO is not the cause when their capsule is clear. If they're happy for a while and then they develop PCO, then it's the cause. But unfortunately, laser capsulotomy is a reimbursed procedure in the United States. And so, again, the first thing surgeons do when their patient's unhappy, they open the posterior capsule. But there's very little literature on the subject. There's just one report that showed greater CME with an open capsule, and yet the incidence of exchange is real. 1.5% overall, and as I showed you before, nearly 6% with multifocals. And again, unfortunately, surgeons open the capsule even though it's not the right way to go. Here, this is a multifocal exchange for a 3-piece monofocal. So we looked at our own results, and we published this within the last year on the difference between patients who had IOL exchange with an open capsule and patients that IOL exchange with an intact capsule. And what we found, and we were surprised by the outcomes, was that the incidence of complication, well, let me go back, I'm sorry. The incidence of complication was no greater in terms of CME, intraocular pressure control, posterior segment complications regarding retinal detachment, retinal tears. They're exactly the same statistically in both groups. But what was different was the optical outcome. And that is that we had for those patients who needed, most often those lenses were either in the sulcus or optic capture, we had about a 3/4 of a diopter difference in induced myopia in the bag exchange group versus the open capsule group. So that also is something your patient needs to be aware of. One of the problems that we have also is IOL exchange with a phimotic anterior capsule. So some years ago, we started doing femtosecond laser secondary capsulotomy. This is with the catalyst, and you can do it also with the LensX, which I know you have. You just have to reset the gates, and then you can do a secondary anterior capsulotomy, which will greatly facilitate getting that lens out. So here I'm peeling away the laser cut anterior capsule, and then again I'm going to use a femto spatula to get under the optic, get it out of the bag, cut it again, and then replace it. So these are the 5 pearls, knowing how and when to exchange. I'm going to talk significantly about dysphotopsia on another time. So I think I'm going to eliminate that in the interest of, how are we doing on time? Because we're done. All right, okay, in terms of time. So I know we started a little bit late. So this is another cause. I'm going to talk significantly on this subject on another time. So I won't talk about dysphotopsia now. I guess I'll end where we are given the time. Are there any questions that people want to direct to me?
Yes.
Okay.
Thank you very much, Dr. Samuel, for this great presentation. I will open the floor for a discussion or questions. Dr. Samar.
Good morning, everyone. Welcome to Riyadh, Prof. Samuel Masket. So I just have actually 2 questions and 2 comments. The first one is with regards to the dysfunctional lens index. How accurate or sensitive, in your opinion, when you judge a person who had a previous cornea transplant or a laser vision correction, and you want to, make your final decision whether to operate or not to operate, for that cataract? That's the first question. The second one is that with the increased number of ophthalmologists undergoing laser vision correction, what would be your first choice for the ophthalmologist if they already had that, procedure and they want to have the cataract done soon in the coming 3 years, or those who never had any previous, corneal intervention? Any one of these premium IOLs that you mentioned. The 2 comments which I want to mention is that the first one, I noticed that you cut the lens for the exchange in the last slides after you open the capsule. In the femtosecond, you've done the posterior capsulotomy, and then what isn't it that it should be like the reverse, that you remove the lens first and then you take out the capsule just to avoid any unnecessarily vitreous strands coming on your way? I thought this should be the opposites. The second one is that I echo your comments with regards to the toric IOL. That the topography or tomography isn't necessarily, as I've seen a lot during my practice, a lot of my colleagues who were not anterior segment surgeons were canceling a lot of their patients, especially glaucoma patients with advanced, glaucoma, just because they don't have the IOL, the toric IOL power, in the place.
You have a lot of questions. You may need to repeat some of them.
No,
Let me start.
no
The first one about dysfunctional lens index. I'm not very impressed with the accuracy of that. I call that a random number generator. I don't rely on it, particularly in, I know where you really want to use it as an aberrated, in
Correct.
someone with an aberrated cornea. I don't rely on it, to be frank with you. That's number one. Then you had I think the easier question then is post-refractive calculation. I think most studies today, most of the literature would say the BU2 Barrett is probably most readily available, very accurate. So I would use Barrett, but you can apply all of them. On the ASCRS, again, you don't have to be a member. There are a number of formulae, and you can use the average. I developed a formula a long time ago. If you know what laser correction was done, it's very accurate. But today, it's 20 years or so since people have had laser, so that number is not readily available. But I think Barrett True K is probably the best way to go
Got
on
you.
that.
And the
or
IOL?
the most widely available.
And the IOL of choice?
The IOL choice?
Yeah.
Yeah. I think people
For an
make-
ophthalmologist, for an eye of ophthalmologist.
Oh, for the eye of an ophthalmologist.
That's my question.
I'll tell you something
It's
very
very tricky.
interesting. Over the course of my career, I had the opportunity to do the cataract surgery for quite a, well, not a large number, but a significant number of ophthalmologists. Not one requested a diffractive optic IOL. Their mothers, their wives, but not them. So my concern was always about quality of vision under the microscope. So that's why I said I was very surprised in that study we did to learn that patients would trade quality for spectacle independence. I don't think that applies to everyone, though. And for the ophthalmologist, I still think I would. There is a tool, by the way. There's a device called the SIMVIS, S-I-M or S-Y-M-V-I-S, that was developed in Spain. It is now, Susana Marcos is the one who developed it. She's now at the University of Rochester with Scott McRae. It's a headpiece put on, and you can actually dial in through adaptive optics. You can create this vision with the variety. You can dial in a panoptics. You can dial in any number of IOLs. And I actually played with it.
Yeah.
And actually, I
like
would
a
have
simulator, you know,
What?
it's like a simulator. You know?
Yes, it's a simulator, but it really works. So this is something we were going to study, and it never happened. But long and short, it is commercially available. It's not inexpensive. It's about $70,000 US. But it is a tool that I think that will be probably come down in price. Maybe it'll be competition. But that's something you should be aware of. Okay, now you mentioned something about the glaucoma patient. I didn't quite understand that one.
Yeah, I mean, you know, like in the glaucoma, patients with advanced optic nerve, you know,
Yes.
glaucomatous, you know, damage. I've seen a couple of physicians who were trying to implant the toric IOL for those patients.
Yes.
And I found it's really unnecessarily with their, you know, just like, you know, their central islands or, you know, altitudinal defect just based on that one. And not even looking into the topography or tomography prior to the, you know, decision. So that's my concern. That nowadays a lot of non-anterior segment surgeons they're just making their decision based on their IOL master, but they never do the tomography or topography and try to correlate. So that's the example,
Right.
yeah.
So as you
I
saw,
mean,
the
your
example I
message,
showed, when you put in a toric lens, you cannot even consider, you have to have an analysis of corneal shape.
Agree?
At least topography, if not tomography, and better both. We use a lot of instruments. We evaluate anterior and posterior cornea. We do as much as we can to determine corneal shape before we'd ever consider a toric lens. I mean, I think it's contraindicated to put a toric lens without an analysis of corneal shape. I don't think you can rely solely on the keratometry of the IOL master. Also, with regard to glaucoma patients, there's not a downside to the use of a toric lens, but in terms of reality, in advanced glaucoma, spectacle independence is the least of their problems.
Agree.
Another reason for ophthalmologists not to have their trifocal in their eyes, they don't see problem with using glasses after surgery.
They don't see what?
Problem with using glasses after surgery.
Right, right, exactly.
Yeah.
Any more?
You had one more question about the...
Yeah, in regard for the
The
last
capsule.
question of Dr. Samar,
second.
the IOL exchange, you did anterior capsulotomy or posterior capsulotomy?
Capsulotomy.
Oh, I'm sorry,
yeah.
I'm sorry if that confused you.
Yeah.
That's an anterior capsulotomy.
That was an anterior?
That's with an intact posterior capsule.
Okay, got it.
Okay?
Okay.
So I have not done that in a patient with an open posterior capsule, although you could, but you would still then have to deal with vitreous. The problem when someone who has an open posterior capsule is it's almost impossible to put the new lens in the bag. You can't separate the leaves, the bag, you know. So I wouldn't consider doing that, but if it was very phimotic, I would, and it had a closed capsule, you could do it to enhance your ability to get the lens out. But the reason to do it is to maintain the bag so you can put the lens back in the bag. If you're not going to be able to do it in any way, you can then still consider relaxing incisions intraoperatively with a scissor. But the reason to do that is to create like almost make the eye start all over again. But if, yeah, you can capture the optic, sure.
Thank you.
You're welcome.
Yes, Dr. Arwan.
We need to get
Thank you very much, Prof. Samuel. I have a question in cases with open posterior capsule, like post-TIAG capsulotomy, and the patient has refractive surprise. Would you
Has what? I
consider
didn't understand. The patient after with open capsule?
post-TIAG capsulotomy,
Yes.
posterior capsulotomy? Would you consider lens exchange or Bigeback IOL?
Or what?
What,
would- or what?
Bigeback IOL, secondary IOL.
Oh,
Is it
piggyback.
safe to implant
All right.
Bigeback IOL?
Given my choice, if I had the right IOL, you're going to encounter fewer problems if you piggyback. The risk of piggyback is always decentration, iris chafe, UGG syndrome, which is another why I prefer silicone to acrylic in the sulcus. But the open capsule, again, in our experience, I didn't find a greater likelihood for complications, but 80% of the patients, or maybe more, close to 90% of the patients with open capsule required vitrectomy, who were very comfortable doing that. But I think if you have an open capsule, you're less likely to be accurate with your outcome if you're placing the lens anywhere but in the bag. And if you have an open capsule, you can't put it in the bag. So in that situation, I would piggyback. If the iris was normal and, you know, wasn't a very short eye, if you had plenty of space, I would prefer a piggyback.
Any further comment or question? Okay, thank you very much, Dr. Samuel. And by that, we'll conclude our session for today. Thank you very much.
Thank you.